there. This is Dr. Braunwald. You were chairing. Everybody was there. I'd like to just go a little bit down. Just press here. And so just listen. This is 12 years ago. And I was telling Dr. Braunwald, what have you accomplished in 12 years?
Okay, Naghavi, Dr. Shah, a pleasure to be here. And I want to make a few comments about the way I have been thinking. It's not a unique way, but at least put together the way I've been thinking about identifying and managing coronary risk in 2004. These are basically principles. So the first is that the prevention of acute events has to be the primary goal in cardiology. Treatment, which we spend a lot of time on, I've certainly spent many years in treatment, is locking the barn door after the horse is stolen. We have to recognize that. So prevention comes first and foremost. And as you heard from Jim Willerson, the magnitude of the problem is really immense. But what Jim didn't say, that is a third of cases of sudden death and of acute MI occur in previously asymptomatic persons. And previously, until, maybe 15 years ago, these were regarded as acts of God. No one knew where they came from. People were suddenly struck down, often in the prime of life. Now we know, and this I think is one of the great advances in medicine in the last quarter of the 20th century, we now know that these are not acts of God, but these individuals usually have preclinical disease, or they have classical risk factors, those that were identified by Framingham, or what we now call novel risk factors. And the imperative is to identify high-risk asymptomatic persons prospectively, ahead of time, to provide intensive prevention. All individuals who have clinically apparent atherosclerotic disease require intensive global risk factor reduction. That's a given. But that's secondary prevention. Some patients have unstable plaques, which I would call accidents about to happen, and of course these have to be identified. So this is my little pyramid. Everybody has, this is the fashionable thing to have. I'll show you my pyramid, you show me yours. And that's right. So this is my little pyramid, which takes patients, at the base of the pyramid are individuals who have no apparent risk factors. And I think people would say that if you have less than 1 in 200 chances of having an acute event in adults, this is for adult people, a year, that would be defined as low risk. That doesn't mean that that couldn't become intermediate risk somewhere in the future. But we can't concentrate on that group now. Intermediate risk now is 0.5 to 2% a year. And I think that a lot of the guidelines that the European Society and Framingham have focused on the higher risk group, the 2 to 15, and I've added a very high risk group, the more than 15% per year group. So, how to go about it? Now, these are principles. The details, I think we can argue. We can argue about the details. So the approach to the patient is some kind of clinical evaluation. And I don't want you to argue with me whether the Framingham risk score or whether the Munster risk score, and there are a number of risk scores available, and how good is the Framingham risk score in Africa or not, but some clinical risk score. And for the moment, rank in the Framingham. And some marker of inflammation. Professor Masri was the first to identify C-reactive protein. There are others, and I think that still needs some sorting out, but let's begin with CRP. Let's look at cholesterol, obviously the fractions, as well as glucose. And that gives us the opportunity to do a first cut. And with this first cut, about 40% of American adults will turn out to be low risk, defined as less than 0.5% a year. That's the one event in 200 a year. And these are suggested to have lifestyle recommendations and follow-up. And that is follow-up depending on the age. We have intermediate group, 1.5 to 2% a year. And that, for American adults, unfortunately, is about 50%, even larger than the low risk group. And these, we think, I would suggest, require additional testing. I'll give you some ideas. And then there's a high-risk group, more than 2% a year. That's about 10% of the population. That squares with the numbers that Dr. Wilson showed. And for sure, these need intensive global risk reduction. So, what is the additional testing? It would be non-invasive imaging in an effort to identify patients who have vulnerable plaques. And here are 3 methods. So we've done the clinical, and we have done the obvious biochemical, such as glucose, cholesterol, hemoglobin A1C, C-reactive protein. And now we've identified a group that is at least at intermediate risk. And we have a series of non-invasive imaging techniques or other tests. Actually, the arterial brachial index is, the ABI is not an imaging technique, but it does give us further information about vascular disease, EBCT, and intermedial thickening of the carotids. Those techniques are available right now. And in a patient who was defined as being at intermediate risk, and if this further non-invasive imaging, non-invasive testing is negative, then they descend back into low risk. But remember, they've been identified to have some risk factor. They may have hypertension, isolated hypertension, or isolated LDL elevation, and they need risk factor reduction of a single risk factor. If the non-invasive testing indicates that they are high risk, then they need intensive global risk factor reduction and some non-invasive detection of unstable plaques. And the non-invasive detection of unstable plaques, I think, is the subject of this meeting, or a major subject for this meeting. And I won't preempt what the techniques are, but I think that this is the group in whom such non-invasive detection. And if that's positive, then we're now getting into a very high-risk group. These are the accidents about to happen. And I think at the present time, we need to think about going after these plaques with some invasive detection device. Again, these will be discussed here. So this is how you identify the patients who need the invasive detection. And now we're getting pretty close to the top of the pyramid. And if we find them and we're dealing with a population where the risk is in excess of 25% a year, and now we come right smack up against what do we do. I think that there is a lot of work going on currently on novel anti-inflammatory compounds, because the basis of the unstable plaque, the important role of inflammation, anti-thrombotic therapy at a high level, and people are even talking about bypassing unstable plaques that have been identified with surgery or multiple drug-eluting stents.
I wanted to segue to the last part. So this is 12 years ago. I think you agree that the premise really hasn't changed. That's exactly where we are. And in fact, we started SHAPE from that meeting, the SHAPE guideline. The difference was that we think that a larger population should get non-invasive imaging than that time. But the reason I wanted to the bottom, to the last part of what Dr. Braunwald said, and the billion-dollar question here is, I asked him, so what? What are you going to do? Now you found this vulnerable plaque patient. And you know, he didn't hesitate. He said, coronary artery bypass is on the table. This is an asymptomatic patient. You know, we don't have any. So I'm going to throw the topic back to the chairman and co-chairman. Please shed light. What is the answer to this question? We found the vulnerable patient. We developed this algorithm. What are we going to do with these people?
You know what? Obviously, as you are saying, we still don't have the answer. And first of all, can I get this clip from somewhere?
Yes.
It's on the website. It's on the website.
Yes.
Okay. So the first important thing that when you look at this data and you go by the CT angiography, we had demonstrated that 22.5% likelihood of having an event in the next 2 years. But when we look at the 10-year follow-up, the risk is approximately 18%. So we are not quite there, what Dr. Braunwald wanted, 25% or more. Unless you are able to pick up 25%, you will not be able to justify a patient to come on a table and do something that you have 1 in 4 chance of dying in the next couple of years or something like that. So unless the 25% that he is coming to is in the next 1 year, because he converted all the framing average score from decade, he brought to
1
yearly.
That's right.
So if he is going to do that and he is wanting 25% in a year, nothing predicts that at this point in time. Unless we are able to look at the dynamicity and we are able to say, okay, it is not the high-risk plaque, it is a progressive plaque. If we are able to show that it is a progressive plaque, probably we might be able to reach there, but still we are not there, first of all. So we do not have a way to identify that positive predictive value what he is expecting, number one. Number two, putting in a stent might be still a possibility, because I don't know how would I like myself to get opened. But stent might be a possibility, but even before we go there, most important thing is now we have a PCSK9 which can squeeze you to 20 mg% of your LDL. And after that, you probably might be able to bring that line back to close to zero MACE rate from the primary prevention as well as secondary prevention. And Amit's yesterday's presentation of with Shekhar Kathiration.
That was the other Amit, Karen.
It is not you?
No.
Oh yeah, come on, you know, like your stature in my mind went 20-fold up, believe me. So the lifestyle changes, I mean, it is all about lifestyle changes. You know, genetics may give you a risk factors, but it doesn't give you the disease. You know, and changing the so that study was something yesterday, what was presented, and so So the fact remains that at this point in time, I don't think we are there. You know, so his question still
12
remains
years
there.
ago, 12 years passed by, few things changed. CRP is no longer as sexy as it was in 2004. Coronary calcium is a lot more evidence and solid than it was then. But 25% were not there. In fact, that was my topic when I started putting the agenda with David. What would be the percentage, 50%, 25%? So Dr. Braunwald puts it on 25%. I want to go around the room and really suck everybody's brain, because that was the purpose of this meeting. This one.
Can I say one more thing,
Yes,
if you don't mind? We just put in a featured research session for ACC, and we have Chimane population from Bolivia, and we have looked at their carotid ultrasound as well as we did the CTs on them. And this is a tribal population. These are the same hunter-gatherer kind of a population which lives there. And their LDLs, lifetime LDL is never been higher than 70 mg%. They have zero calcium scores. Zero calcium scores. And believe it or not, when we look at their CRPs, not HSCRP, I'm talking of CRP, it ranges between 7 to 10. They have got thoracic calcifications, but coronary calcium is zero. So in my opinion, inflammation is not the way to go. CRP, what we are talking of, CRP is not causing any problem because coronary calcium. And that is all because of aortitis, which is because of tuberculosis, aortoarteritis, or whatever else it is. But the coronary arteries are squeaky clean. 90 years old people, carotids, have no plaques.
And this is a population study that
We have done 750 CTs, 3,000 carotid ultrasounds. We wheeled in the trucks there, and it is an amazing population that we have worked on. And only reason, one, and that is their LDLs are under 70. So we did a Texas population in Crawford from dear Mr. Bush's place, and we find that at the 30 years of age you start developing carotid disease. By 80 years of age, 100% people have the plaques. Quite like Dr. Fuster's data from Netherlands and Denmark from the HRP study, not HRP, bio. Right. So then the next important thing, I went to my guru's town in India. There the people are vegetarian, they are farmers, none of them is a smoker, they don't touch alcohol, non-vegetarian, all vegetarians, and they meditate twice a day. Everybody is happy. We did 1100 ultrasounds in one day, carotids, okay? Because they all collect for his birthday on 25th of January, and there are approximately 20 million people collect there on that particular day. 20 million. So we were able to put in a camp and randomly did everybody who came in. So we had 12 stations, 24 hours we worked. The people from Guinness Book of World Record were there, so we made a world record on that day. For the maximum number of carotid ultrasound, maximum number of blood draws, maximum number of screens. So we had 4 records done on that day. But anyway, there the disease is postponed 1.5 decades. Based on the carotids. And then we go to this Chimane population, disease has postponed 3 decades. Paper is in Lancet. You will be seeing it.
So strong correlation with the LDL?
Only LDL. One thing. It's all LDL.
Okay, wow. Okay, we're going to go, and I'm not going to let anybody leave this room till we suck your brain, because that was the purpose.